And thanks also, of course, to the organizers for inviting me to this really quite exciting meeting. I've been working on the scientific committee of the Alliance really ever since it began a few years ago, and it's a really short history. What I have learned is that actually, by working together, a great deal can be achieved, and I think this will run through the talk that I give you. So, what I want to do in this talk is very straightforward. I think for those of you who aren't fully aware of what the Alliance is, I think just a little bit of orientation is needed about why it began and what the mission is. We heard a little bit about this in the talk at the beginning of today's meeting. But I then want to move on to really what we're doing. What are the priorities that we see? How do we choose them? And where are we at the moment in trying to get cures for people with progressive MS? So I'm not going to tell you in any detail about individual bits of research. I mean, the amount of research going on is massive, and you can't really cover it in a talk like this. So this is really an overview about strategy. So by way of introduction, and this is an old slide, the thing people with progressive MS feel is that they're ignored, that we're not doing anything really to help. And that's because we haven't really come up with much in the way of treatment. So we did bits of analysis at the beginning of our progress and our whole project. And this is, as I say, old information. But what you learn is that actually investment in progressive MS is not negligible. $100 million is probably a vast underestimate right now. And of course, it doesn't cover the fact that we're also doing clinical trials, which require separate funding. And there are many clinical trials going on, actually. I mean, when this slide was put together, there were over 40 trials going on. Some of these have now produced results, some have been positive. So we're not starting from a position of no effort. The problem is that that effort isn't really producing results. So we need to move on to asking why. And I just want to take you through this slide a little bit, because the real problem is that actually the way we discover drugs is really not working very well. It's expensive, it takes years, people don't want to do it. And the whole process needs to be investigated. So if we actually take a look at what we do, we begin by discovering targets, the kind of work which leads to understanding the pathophysiology of the disease. That's hard enough, actually. Then we have to develop drugs. We test them in animal models in general, in laboratories, and again, that takes time. These models are very slow. It takes time to actually run these animal trials, if you like. And then there's the very expensive business of doing clinical trials. And your problem's not really over by then, because you then have to get regulators to believe what you've done makes a difference to people with MS. And even when you've done that, you need to get money to actually pay for the drugs. Now, this process takes 10 or 15 years. From having an idea to having a drug takes a long time. And you have to have about 1 to 2 billion euros to spend. So you can understand that if you don't have success or a track record of producing results, the appetite for risk is really very low. So what can we do to reduce this? Well, the first thing is that we're starting to see success. This model isn't by no means outmoded. We do have success coming through. You know that we're seeing success with phase 3 trials, ocrelizumab, siponimod. We're having success at phase 2 with simvastatin, clemastine, other drugs. Many of these have been tested through this whole process. But we can't carry on like this, because actually the need for treatment is urgent, and this process produces results very slowly and inefficiently. We need to de-risk it. Now, efforts have been going on around the world. This is just our local effort in the UK, we began around 10 years ago. I was completing a trial of secondary progressive MS at the time and became involved in this process, which actually is still going on. We recognized the urgency of the whole business by saying that we actually needed to take a view of the key problems and attack them with small groups who could actually break the problem up and look at individual components. So we started by asking about targets, we had outcomes of clinical trials and so on, and we needed to get funding. All of this came together. But as you can see from the bottom, it's a bit hard to see, but we were pretty optimistic. We thought that starting in 2010, we would have a trial underway within around 2 years. So we did this, the process went on. In fact, it actually completed in 2014 when Jeremy Chataway launched the MS SMART study, which was reported just recently. But it worked. By having a concerted effort, we showed that we could do something. Now, it was around the middle of this that the Alliance came together, at least as an idea. In fact, it really came to fruition around 2011. But recognizing the efforts that were going on everywhere, people came together from many different MS societies. And we've seen this already. There's a mission. We need to expedite the development of treatments for people with progressive MS, not just disease-modifying treatments, but symptom control. And we thought that there were two really important things that we had to embed in this process to begin with. The first is that this is an incredibly complicated process. We have to get people to work together. That isn't always easy. And lots of money is needed. So this needs a global effort. And by acting as an honest broker, by being a group that didn't have an interest in getting a result other than making it happen, we felt that we could act as that body. And the second thing is that everybody has to be involved. There's no point in trying to do this work by just having a group of academics or charities. We have to involve everybody, including regulators. I didn't say to you at the very beginning when I was talking about the problems with the drug pipeline, but if you're starting basic research and trying to develop a drug, your eye has to be on the goal at the end. And if at the end your product is too expensive, the example I can give you is ocrelizumab. We have ocrelizumab, a proven treatment in primary progressive MS. In the UK, we're not able to provide it because it's too expensive for the benefit it gives. That's something you need to consider from the very beginning of drug development. So we need to involve regulators, we need to involve pharma, everybody has to be in the room. Okay, so this doesn't project very well, but you've seen the slide already this morning. The membership grew from a few people to many people. So we have MS societies from around the world, from Australia through to North America. Many of the European societies are involved. We have industry, all the key players in industry are involved. And importantly, we also have key donors, people with money who are willing to invest in this project. And this has exploded over the last 5 years. So who are we? Well, I think this slide captures a little bit of this. We are really the MS community. We belong to the community. We're not separate to it. We're embedded in the community because we actually represent most people. We have people with MS, we have donors, we have charities. Everybody is in there, in the room. And the thing that I just want to also just point out is that there's also something which is the lack of overlap. We also involve people from research in other areas. So we think that people who work on Alzheimer's, Parkinson's, other neurological diseases may have lessons for treating the kind of disability that occurs in MS. So the strategy, well, again, we've talked about that before. What we want to do is to get collaboration around the world on key areas. And the targets that we have, the areas, were defined in a position paper in 2012. And these are not mysterious, these are obvious, and they haven't really changed over the years. It's just that we have tackled them a little differently. So we want to understand why progression happens, we want to design trials, we want to treat symptoms. And Bob Fox and others who put this together, it's the usual suspects, they basically, we came up with this paper which really set a position from which we've evolved. How do we implement the strategy? Well, we convene expert groups. We identify the key roadblocks. The kind of work which we all do as researchers is intensive, but usually it's progressing towards a target. What then happens is a roadblock. You can't get beyond that. There are key blocks in the whole process. We identify those, we issue research calls to attack them. And finally, we engage with pharma. So Professor Comey leads that effort. We are engaging with pharma, not just because they're developing drugs, because they have data, because they can guide our strategy. So we began by simply throwing out a challenge. We used the Gates Foundation as a model for this, and we just wanted to shake up the community a little bit by asking, do you have ideas that aren't getting funded? They're too crazy, or people don't believe you. And we thought that we would just ask for innovative ideas. Are they out there? Are we missing something? And you can see here that these were small grants, 75,000 euros, just a seed funding to get ideas to work. We weren't sure what would happen, but actually we had nearly 200 applications, a lot of work to sift through all that. And we gave grants, as you see, around the world. And there were some interesting things. Again, hard to read this slide, but we had ideas coming at us from all directions. New ways of thinking about myelin damage, new ways of measuring disability. Things which are now becoming quite fashionable, looking at remote sensing of activity, for example. Paul Matthews set something up there. We had clinical trials coming our way. Some of these are actually moving into further stages as the work goes on. So there were ideas out there, but the field was ready for innovation, and we felt that we could actually try to stimulate this in some way. We then held a meeting to really try and iron out our policy, and here Marco Salvetti led with Bob Fox in running this meeting. The question we asked, and the simplest questions are often the hardest, is if you don't understand the real mechanisms of disability, how do you go about designing treatments for them? You know, because if we wait for all the answers, we will never actually do trials. So is there a way that we can get around this essential roadblock, incomplete understanding? And this was one of the things that drove our thinking for a while, and indeed I'll come back to this in a minute. But it led to the next phase of development. That was these collaborative awards. And what we demanded was that people should work as international teams, and that they should come up with big ideas. 4 million euros was on the table, and again, we wondered how much we would get back. In fact, we had over 50 applications, and each of these required an enormous amount of work to submit. International collaborations were formed. We had people working with each other on ideas which, even if they have not been funded by us, have then led to other progress. So again, we've acted as a body that stimulates work. And again, the fields that we wanted to stimulate are the same as before, really. Find out what's going on, find drugs for it, design the right trials, work out how to measure disability. So I want to go into this a little bit with you. So here are the shortlisted entries, if you like. And if you look at the ones in gray, these are the ones that we didn't fund. And among these, you'll see key workers, key researchers in the field of MS. Really high-level applications, looking at finding biomarkers, looking at finding disease mechanisms, and so on. And I'll tell you a little bit about these in a minute. In bold are the other teams that won, if you like. And we'll hear from Linda Ottoboni in a minute about the Martino project. But we have two drug pipelines which are very innovative, which are looking to produce results in the next few years and providing us with drug targets. Doug Arnold in Canada has an international collaboration where he is looking at existing data. The idea is that actually buried in the haystack there is the needle. We can get a signature, if you like. If we look at lesion activity, if we look at atrophy, if we look at MTR, individually these things may tell us very little. But if we combine them by using intelligent machines, by using other advanced statistical techniques, do we get a signature of MS? And that's underway. Now, the asterisks on the first two projects in the first column are there to tell us that these have been judged to be so important and so well designed that actually individuals have funded each of these projects. So we were going to give 4 million euros to Fran Quintana in Boston, for example, but a single donor has funded that entire study. The same has happened with Gianvito Martino. And the Feinstein project, the one which is looking at exercise and cognitive rehabilitation, wasn't funded. It just fell below the mark. But again, so important is this project that has been funded independently by the Canadian MS Society and others, and that is underway now as well. So these are areas of research which are incredibly fertile and which are underway. Now I want to turn to some matters of, if you like, research. So how are we going to make progress? You know, the question which Marco asked about how do we make progress in a field where we don't know the answers? Well, the thing is partial information can be helpful. And here we have an example. So Sergio Baronzini in San Francisco is leading in the Martino group on trying to use computer techniques, if you like, information network theory, to try to work out targets for drug treatment. So you don't need to know the answers. What you can do is take tissue samples, you can work out what are the abnormal expressed genes or proteins, you can feed that information into computer networks with other kinds of information to do with headlines, genes, demyelination, disability, and you allow the network to find the answers. So Sergio has already found hundreds of drugs which may be effective in MS from this kind of thinking. We then go on to how do you test these drugs? Well, the answer there is at the moment we use laboratory techniques, animals. Each of those takes months to do. We can test a single drug, and really progress is incredibly slow. So what do? Well, you have high throughput screens. And here's an example, again, a little difficult to read, but on the left is work from San Francisco and Cambridge. So this is no longer science fiction. You can actually use oligodendrocytes and grow them in little wells, shown, whoops, let's go back a little. There are these little micropillars, and you can see if oligodendrocytes grow on them. So this is high throughput screening to see whether you can promote remyelination. And you can test thousands of drugs this way. So this works. Clemastine came out as a winner, and many of you will know that clemastine was shown to actually cause remyelination in optic neuritis, a human trial. Early work, but very, very promising indeed. And people in Alzheimer's have been talking about this kind of thing for years. So here is a paper some years ago showing the network, working out drug targets. And you can use engineered stem cells. You don't have to actually take oligodendrocytes. You can make these cells, and we'll hear about this again in the next talk. But you can actually engineer cells, even from people with MS, to work out whether these drugs are working, and you can screen for lots of drugs. So the next thing is, well, how about finding drugs other ways? So you can actually just do it in your armchair. I mean, you don't actually have to do any work at all. You just sit with your computer. And the idea there is you look at big data. So again, we heard about how much data is out there. So in the UK, the way in which the drugs were identified for the MS SMART study was by having expert consensus, if you like, by scouring the literature, by seeing whether there are drugs which may have effects in MS, but which have been reported in small studies, animal work, or indeed outside MS. So this paper, which was headed up by Siddharth and Chandran, exemplified that approach. But others in pharma have said, well, that's really a very limited approach. Actually, the amount of data in the cloud is immense. Maybe there are clues from just searching data intelligently. Maybe people are reporting side effects. People reporting problems with treatment in other areas which may be relevant to diseases that you're interested in. This is very new, but I think that we are going to have to search the data that we have already in more intelligent ways, and this approach may give us drugs to repurpose. It's certainly something we're very interested in doing. Third, what about clinical trials? So again, at the moment, we do a trial where half the people are given a placebo, half are given a drug, and we wait 2 years. Can we do better? And we have to do better, actually. Those trials are going to take a long time, and the failure rate is too high. So we heard about the whole approach we adopted in the UK. So Jeremy Chataway adopted this. And the idea is, first of all, here, you have a multi-arm study. You do 4 trials in one. You compare 4 drugs against placebo, or 3, 5. And the more the drugs, the more the power of your study. But you can do better than that. You can take something from the cancer field. And what they do is they test drugs, and then they throw out the losers. And they test the winners. So this is a multi-arm, multi-stage design. And you can do even better than that. You can have this design, but you can replace the losers with new candidates. So you have a rolling design which can run for years and years, where you keep testing new ideas. Now, this is full of immense difficulties. It's easier in cancer. The endpoints are easier. In MS, we have a problem. But we're trying to get this to work, and this is a major focus of the kind of work which is going on in the UK at the moment. And then we have Professor Salvetti with a beautiful trial design, again, looking at combinations of treatments or treatments tested individually, using many different outcomes and using, again, statistical methods to work out the winners and piling the patients into the winning group. So again, another idea for trying to improve the way in which we do trials, to get really answers quicker and with more drugs, and using combinations. Okay, so all of that is underway, and that's really been underpinning some of the work that we have been interested in, and we'll hear about that, as I say, in a few minutes. So what about working out whether drugs work? So, we wish we had the same thing in progressive MS that we do in relapsing MS. In relapsing diseases, we run short studies, 6 months. We test drugs, we look at whether they influence MRI lesion activity. Now, the reason that works is because in relapsing disease, inflammation, energy failure, the primary things that are driving the disease in the relapsing stage are actually the cause of the lesions. So you have a very clear relationship between something you measure on an MRI scan and something that's causing the problem. The difficulty in progressive MS is that there's a distance, there's a buffer in between, lots of different processes which are really too many to put here. These are just a few ideas. But these are in the way. That's what takes over from inflammation and leads to the kind of thing that causes disability. Well, measuring lesion activity is not really a very useful way of doing this. We've tried with MRI to look at neurodegeneration, so atrophy of the brain. Again, that takes a long time to mature. It's a slow process. Can we do better? And the answer is, well, maybe we can. So again, we heard earlier about neurofilaments. So these are scaffolding proteins. They hold axons together. And if axons get damaged, they get released. But you don't just measure them in the spinal fluid, which is difficult. People don't want lumbar punctures. You can actually now measure them with extreme sensitivity in blood samples. And the good news here is that we're starting to see positive results. In relapsing MS, this is a field which is already very active. But we have results in progressive MS. So the lamotrigine trial I did back in the day 10 years ago was analyzed by Shamli Ganapavan, and heavy chain neurofilament was lower in people who actually took the treatment. But importantly, there have been 2 phase 3 studies now, and there's another one which may well analyze results shortly. But essentially, we know that actually siponimod works in secondary progressive MS. We know also now that siponimod reduces neurofilament levels in the blood. And we just reported results from a trial which I did with Biogen, this international phase 3 trial with natalizumab. The same results were found. And it turns out this may be a very sensitive way of picking out disability. So again, this helps us to plan testing treatments. And the Alliance has taken a major sort of view, if you like, that we are interested in promoting this work. Now, this kind of shows how we do things. So the whole process by which biomarkers will be validated starts with discovering them and ending up with going to the regulators to say, this is a good idea, use it. Now, we don't have the resources or the inclination, if you like, to discover biomarkers, to fund that work. That's going on. It's a very fertile field, and really there's no point in us trying to tell people what to do. There's little point in us getting involved in the very end stage of this. The clinical implementation will happen whatever we find. But we are involved in the middle here of trying to actually engage people to try to understand what the process is by which a promising target, a biomarker, can be taken through the development stage. And that's really what we're doing at the moment. I shouldn't really finish without talking about this whole thing about disability. So the ultimate goal is to provide treatments which have a meaningful effect on people and their lives. I mean, that's what the regulators want, and despite all the difficulties that they raise for us, the fact is that's all they're interested in as well. It's to the benefit of people with MS. At the moment, you know we measure disability badly, especially in progressive disease, so the EDSS. And the idea is really to do this better. So again, a very similar initiative that I've been involved with, this is the MS Outcome Assessment Consortium. And this has been working for about 5 years to work out better ways to measure disability. I can tell you this is a very, very difficult thing to actually achieve. It seems easy when you start, and then you discover the problems. But we're a long way ahead, so we've already got various position papers talking about elements of the previous MSFC scale with some updates, looking at cognition using the symbol digit modalities test and so on. So we have a position that we say we're in a better place now. And the FDA has accepted that at least the walking test and the upper limb function test, the 9-hole peg test, are valid outcomes. And we're meeting actually next week with the EMA in London to work through this whole thing and see how far we can get. But there is scope for this also to produce results, so that this is the final part of the puzzle. If we come up with drugs, if we come up with a strategy for developing them through early phase studies, this will greatly help phase 3 trials. And other people are working on other ways of looking at disability. This is not the only game in town. So let's put this together. How do we accelerate drug discovery? Well, really the headlines are here. Again, a little difficult to read, but we hope that this pathway will now be accelerated. And we're working on each part of this whole thing. So we'll use network biology, repositioning of drugs to come up with candidates, in addition to all the work that's going on in drug discovery in traditional ways. High throughput screens are likely to take over considerably in validating drug targets. The proof of concept trials that we're designing are going to have a new way of running, and certainly they're going to be more efficient as time goes on. And in fact, we have new outcomes for the registration trials, phase 3 trials. The key thing here, again, is to involve people from an early stage. And the lessons that we're learning are that we involve the FDA, the EMA, other regulatory agencies, we involve industry from the very beginning, so that when you come to the end of this process, you don't have a nasty shock and find that what you've done is simply inapplicable. Now, I can't finish without talking about exercise. I mean, so the quick gain is to do something where you can actually help people without having to wait years. And you know, there's already a lot of information out there about exercise therapy and the fact that it is beneficial. There are also papers that say that exercise is a good thing for people with progressive MS because people with MS still have brains which can adapt. There's lots of information that says that learning is perfectly possible. And then there's exciting stuff out there that says that exercise may actually be neuroprotective or it may have a disease-modifying effect from animal studies. So we're sort of taking more note of exercise, cognitive rehabilitation, physical rehabilitation, not because there are lots of problems, but there are new ways of looking at this, and in fact there are new biological targets. Now, part of the problem is that the studies that have been carried out so far have been underfunded, they've been small and unpersuasive. I mean, here's an example of a really great study. This is in progressive MS, a German study. And what they did here was they took people who had different kinds of disabilities, they tailored exercise to them, and after 10 to 12 weeks, they measured significant improvements. So physical reconditioning led to physical improvement, but also cognitive improvement. But you see, these are 47 patients. And if you go to funders and you say you need to give money for exercise rehabilitation, it doesn't get funded. So we need to work in a much more persuasive way. And we heard earlier about this, the last meeting that we held in Toronto earlier this year, where our aim was really to pull in people from the field of MS, but also outside MS, to ask key questions. How do we go about actually doing this right? How do we take basic research and translate it into a clinical form, which to the benefit of our patients? We need to improve the quality of the research. And so this is, again, a major driver for us. So my last slide, really, I mean, this is where we are. So again, we saw this slide. I mean, we work together, so we share slides. And this is, as you can see, the slide is evolving. But essentially, our priorities are really as they were: understand progression, accelerate trials, enhance well-being. And we have 6 different initiatives going on at the moment: better trial design, fluid biomarkers, and so on. And of course, we're engaging with people as we go along. So really the conclusions, they're very straightforward. And I hope I've given you a flavor of our approach, the themes that we're following, why we're following them, what we aim to benefit. But we involve the key stakeholders. We want to foster collaborations to address the main roadblocks to our mission. And we have innovative solutions emerging. And I think just to end on a positive note, personally, and I think this is a view we share, we get excited every time we meet, actually, as an alliance, but the point is that I think that the prospects for significant advances in the near to medium term are actually very good. Thanks very much.